Welcome to our panel today. I'm sure your panels have been like the panels I attended this morning. It's been a pretty invigorating day. Some really excellent scholarship and excellent presentations today. And for our panel right now, the title is Gender and Substance Use Disorders, and we have Lynn Madden and Catherine Parks who are going to be presenting their paper, The Intersection of Gender and Substance Use Disorders. So we will have some time, plenty of time for the presentation, and then we'll open it up for some questions and discussion.
Welcome, everyone. It's so good to see all of you. We are only here for this day, Lynn and I. The first piece of paper that we passed out is part of our research. It's actually part of our single question survey that we're asking as it relates to the intersection of substance use disorder and gender identity. We want to take a moment just to introduce ourselves for those that don't know Lynn and myself. My name is Catherine Parks Fields. Since I've been here at Union, the focus of my work has been on the construction of gender identity. My emphasis is really on that 2% of the population that I consider gender diverse. And what I mean by gender diverse are those individuals that do not fit into those normative binaries of male and female. Now I'm going to let you meet my sister from another mother and let her introduce herself.
Good morning, everyone. I'll add my welcome to Catherine's. I was fortunate to see most of you yesterday afternoon, and it feels really good to be here. I'm Lynn Madden. For those of you whom I don't know, but I'm not sure there's anyone in the room that I haven't at least taken one course with, so that feels really good too. I want to say this is really a work in progress, and we're planning to use this time like a workshop. So we passed these single question surveys out. If you are interested in filling it out and returning it to us, please do. If you are not, then don't. And there's a consent form attached to the back. And the demographic data, we are planning to use the demographic data to actually just code the responses. We don't know if there will be any correlations or not, but you will not be identified in any other way. My area of academic focus in the last few years has been really on the creation of identity for persons with mental health and substance use disorders that our culture has, that our culture really seems to depend upon. And identity seems to be intertwined with social position for everyone, and in particular for persons who are marginalized. Those identities, for those of you who are public policy folks, those identities are really used as policy targets, right? And we often create policy around identity, and on the surface of things, we say that we are doing something on behalf of a certain group of people. That often doesn't include what they think at all. So what this research is about that Catherine and I have embarked on is really trying to figure out what is under the social, what is really underneath the kind of social assumptions or cultural assumptions that we make about gender and the assumptions that we make about substance use disorders. And we're going to talk first a little bit about why we're concerned about that. What does that actually mean? So we're going to ask you to do with us just a very small exercise. This is from the work of a person named Meg Wheatley, who's works in leadership. But because some of these topics bring up, I think, strong feelings in people who have strong opinions, perhaps about substance use, who have personal experience, or strong opinions about gender, particularly gender that's not heteronormative in some way, we just ask, we use this exercise just to ask you to rate yourself. This is not for us. 5 questions, 1 being not very much and 5 being a lot. How present and undistracted am I? How open and curious do I feel? How brave do I feel to inquire, to take risks? How much do I feel that I'm able to contribute to others? And how willing am I to support their learning as well as my own? Again, the idea behind this is just a benchmark for yourself and to put us all in a space of just thinking about this as a kind of open inquiry, a workshop idea.
And so we also want to tell you that Lynn and I may often cut each other off or finish each other's sentences. So we don't want you to be alarmed or offended for us because we're not offended when we do that to each other. So just so you know, and we're going to give you just a minute or two longer just to think about those questions.
Thank you.
And you're referring to right now?
Yes.
Catherine, did you have a piece of paper for us to fill out or just?
No, you can actually write it on the back of the survey or jot it down, 1, 2, 3, 4, 5.
5 is very much in.
5 is very much. And then just as you take that minute to kind of center yourself in the room with us today, I think we talk about some of the intersection points, certainly as it relates to gender identity and, with me, gender diversity, because what you may not know is 1.74 to 2% of the population, and if we're talking about a United States population of about 14 billion, we're talking about 2.8 million individuals that have gender diversity, that are born with gender diversity or gender identity disorder. So that's quite a lot of people that we haven't made room for.
So we're going to move on. This is a photograph taken by Lincoln Clark. So I think you can see it. It's a photo of a woman named Leah. Comes from a book called Heroines by Lincoln Clark, which features 109 photographs of persons with opioid addiction. All of them are women. The photos were taken over a period of 5 years from 1996 to 2001. And his book begins with this evocative photo of a bus stop where you can see Kate Moss, who's a Calvin Klein model, sticking her hands partway down her pants, and another woman standing in front of her who happens to be named Leah, shooting, obviously shooting out something. Kate Moss is one of the first heroin chic images. So one of the things that drugs do in our culture, have done in our culture, is to create this kind of sense of beauty, right? That this is to be admired, right? That Calvin Klein was the first, after this ad, using Kate Moss, to architect the size 0 jeans. So we'll just leave you with that. Leah died of a heroin overdose in 1999. Her friends who had used drugs with her recreationally, including the photographer Lincoln Clark's, basically would greet each other in public by asking, "Do you know if Leah is still alive?" Right, so Leah became, in many ways, her drug use disorder.
So we're just going to get into some definitions of what we're talking about today. So for gender identity, I used a definition from Raphael Islam Shazoo. And he says, gender identity is another word for a person's private sense of and subjective experience of their own gender. Generally described as one's private sense of being a male or a woman, consisting primarily of the acceptance of membership into a category of people. Gender identity, however, has expanded over the years to include one's innermost concept of self as male or female, or both, or neither, how individuals perceive themselves. One's gender identity can be the same or different than the sex assigned at birth. And so to that, for me, I say I get to define, not society, who I am. I get to say who Kathy Parks is, what color Kathy Parks is. I'm not black, I think I'm brown. So those things, I think we get to decide for ourselves. I don't know how to change this. The second one we looked at, even though our focus for the paper was strictly looking at substance use disorder and gender identity, we found that we intersect so many other things. We intersect race, we intersect age, we intersect sexual orientation. So we brought some of those definitions to the table. This particular definition is taken from the Gay Alliance of Rochester. Sexual orientation is a noun. the type of sexual, romantic, emotional, spiritual attraction one feels for others, often labeled based on the gender relationships between the person and the people they are attracted to, often mistakenly referred to as sexual preference. Sexual preference is how you like to have sex, not who you have sex with.
So moving on into definition, substance use disorders. And I ask you again just to suspend for a minute whether you believe that substance use disorders are a social construction or not. I think they are, but for the purpose of this conversation, we'll go with the definition that comes from the Diagnostic and Statistical Manual, number 5. Substance use disorders occur when the recurrent use of alcohol or drugs causes clinically and functionally significant impairment, like health problems, disability, failure to meet major responsibilities at work, home, or school. And a diagnosis is based on evidence of impaired control, social impairment, risk use, and pharmacological criteria. That piece of it is from SAMHSA. So this is what a substance use disorder, gender identity, sexual orientation. And in the other thing that we really are bringing in as a concept here is from Dean Spade, and he talks about administrative violence. He says that life chances are distributed through racialized and gendered systems of meaning and control. Racialized and gendered systems of meaning and control. Right? So if you go back to a policy frame, like he's talking about systems that are actually created to control certain identities, if you will, or certain demographics, often in the form of programs that attest to be race and gender neutral, such as substance abuse treatment, and merely administrative. Right? So these programs, on the face of it, they claim to be race and gender neutral. Virtually all programs do, regulations do, essentially. One of his central points,
right there at one point, and I want to interject here because if I am a person with substance use disorder and I walk into a clinic and I have to fill out a form and I don't see on that form the box that fits me, I'm subject to turn back around and walk out. So that to me is what I consider one of those forms of administrative violence. It's put in place to help us, but it actually didn't make room for us.
One of Spade's really important points is that the dominant power structure is supported and sustained by the creation of norms that distribute vulnerability and security. So if you tease this all apart, one of the ways of really looking at this is that any kind of marginalization, any kind of marginal identity or marginal social class that a person might consider himself or herself or themselves to be part of, it moves you away from those domains of invulnerability and security, right? So all of the ways that, and when you're looking at substance use disorders and gender identity, you're looking at complex kinds of issues, right? So there's lots of ways that we could do this. You could use all of these things, but really policies are almost always aimed at one, right? Here's our policy on drug crimes. Here's our policy on substance use disorders. Here's our policy on forms relative to gender identity, right? It's not about the fact that that there may be many facets of you, and there are many facets of you as a person. People really get reduced, if you will, to an individual and particular identity.
And so, I'm interjecting again, so I think, or I should say, Lynn and I both think that this creates then a huge issue as it relates to public health. And it's health. If you can't, not even so much public health too, but when you think of some of your other just basic human rights, you cannot, the first form you fill out is your birth certificate. Immediately you have to declare gender. Well, if you're someone that is dealing with a gender identity disorder or diversity, because I'm not sure I even like the word disorder, diversity, how do you solidly say, I'm this at birth? And then it's a spiral because you don't have a birth certificate. You can't leave the hospital. It begins to pack more labels on you. So you do pick a gender. You realize you don't identify with that gender. Well, that's how society has lumped you at that point.
So social identity and personhood becomes really intertwined, as Catherine is suggesting here. There's women writing right now discourses of desire in the narratives of addiction and treatment, and she primarily writes about work that's ongoing in Ukraine. And she says that addiction treatment programs are governed by a system of medical ethics that is inextricably bound up with locally salient ideas about social identity and personhood, which is the same thing that Catherine just said, basically, right? That however we work things out and however we tell each other something is right is a very kind of local or cultural sort of things, and it begins to shape our personhood and our social standing in many ways. So exiting the problematic realm of addiction by submitting oneself to treatment is a move that's entangled with social position and discourses of identity. Who wants to tell somebody that they have a drug use disorder? Right? Why would you want to do that? There's nothing good that comes out of that in the current culture, right? You are forever identified as that person who has a substance use disorder.
Gender identity and social position. Gender identity in the United States is similarly intertwined with social position and personhood, with the dominant gender identity being that of the white European male. In her discussion on how gender and other essential definitions of people are constructed, the French philosopher and feminist writer Luce Irigaray, is it Irigaray? How do you pronounce it? I can never get that. And I love it. Writes, the fundamental model of the human being remain unchanged. One singular, solitary, historically masculine, true, paradigmatic, Western, adult, male, rational, capable. That's it. That's who we all are. Irigaray goes on to say all other persons are identified as a function of their inadequacies with respect to that idea, age, reason, race, culture, and so on. Every other identity is working away from this definition. In other words, all who are other than the reasonable and rational white adult male are less. Using this concept of identity construction, Elizabeth, this was our subject matter that we chose when we first started this case. Lynn and I have done probably 3 projects together now that we co-authored. And Elizabeth was the person that we initially chose who was transgender and also had substance use disorders. And so we followed Elizabeth for about a week or so, just really trying to understand her story and her process. Go ahead, what were you going to say something about Elizabeth?
Elizabeth is a young trans woman who is currently in substance use treatment, and we interviewed her for a couple of hours and on separate days, and so we have a lot of information about her actual experience, if you will, in trying to navigate the system and to stay in the system.
Mm-hmm. And Elizabeth, I guess, has been clean for about a year or so now. She's still doing good. She is literally at one of Lynn's centers.
She is.
And that's not her name, so we're not really divulging, but she is still doing well, Lynn?
She's still doing well.
Outstanding. The compound issues of a gender identity variance from the classic binary male-female heterosexual and the attendant rate of substance use disorders pose major public health and personal health problems. Problems which are largely ignored by the current healthcare system. Sean McKay and colleagues authored a study published in 2014, which was the first to look at multiple types of discrimination and substance use disorders with a focus on the LBG communities. It was not as it related to gender identity disorders. This was the closest we could find linking the two. Using a large U.S. national sample. The investigators test Meyer minority stress model, which posits that discrimination, internalized homophobia, and social stigma create a hostile and stressful environment for LGBT adults that contributes to mental health problems, including substance use disorders. A key point of this model is that minority or other stress is additive to the general stress that all persons experience, thus offers a framework for understanding the health disparities that exist in minority or other persons. Significant findings of McCabe's pioneering study include that half of the LGBT adults who experience discrimination on the basis of gender, race, ethnicity, and sexual orientation in their lifetimes met the criteria for past year substance use users, compared with less than 1 of 5 who reported no discrimination. So we're compounding issues when we're discriminating against people. We're causing, what am I going to say, extra layers that would not exist in their lives, simply because of the way we've structured identity, or we've structured them in society. Certainly these findings suggest that an intersectional lens is the best tool we may have to advance policies that support the expression of gender identity and sexual orientation preference in the healthcare system.
So this is a giant public health problem that is completely unspoken about. We couldn't even find research relative to a transgender population or an intersex population. So as Kathy said, this is the closest that we can find. But of all of the people who identified in this very large survey themselves as LGBT adults who experience discrimination in more than one of these ways that are listed here, half of them meet the criteria for a substance use disorder. That is a giant number of people, half of them. Right? Those who express experiencing no discrimination, that number drops to less than 1 in 5, which is under, by the way, the population rates in general. Right? So this seems to suggest that discrimination, or the way people are treated, or these administrative violence, if you will, these structuralized ways that we treat one another, really are predictive, in this case, of a major public health issue. To put that in world context, the number one reason that people die in the world related to behaviors, if you will, is tobacco use. The number 5 reason is alcohol use. Both of those things are illegal. The 4th reason people die in the world, this is World Health Organization data, is lack of access to fresh fruit. Okay, so these things exist on the continuum of what's in your locally available to you, but heroin and other sorts of things that we spend an enormous amount of time, money, and energy talking about, heroin, cocaine, methamphetamine, they're not on the list. They don't exist on the list. And in fact, the drug enforcement agencies and other agencies' efforts to control the heroin trade results in more deaths than heroin itself actually results in. So again, these are just facts, right? I'm not actually arguing for legalization or not. I'm not having that conversation especially. Just putting in context to you that this is a major public health issue that is, you can't find any research about. It just simply doesn't exist in the literature, and we looked really hard.
And once again, 2.8 million people in the United States population are affected. And that's just on the gender identity side. So compound that with substance abuse, and these numbers are probably huge. And we don't know that. But we will.
Compounding the public health issue is really incarceration, right? So there's another whole set of data about what happens to the health of persons who get incarcerated. When you look at that through the lens, really, of drug use disorders, or so-called drug use disorders. This is from Michelle Alexander. The impact of the war on drugs is astounding. In less than 30 years, the U.S. population in prison has exploded from 300,000 to 2 million people. 2 million people we have in prison and jail today, right? And most of our prisons and jails are for-profit centers that government actually pays for. The United States has the highest rate of incarceration in the world. In Germany, for example, 9.3 people are in prison for every 100 adults and children. In the U.S., the rate is roughly 8 times that. 8 times the rate of incarceration. The racial dimension of incarceration is its most striking feature. So go back to that additive stress model, right? Every time you add one of those identities, if you will, or categories, that increases a person's likelihood of having poor health outcomes. No other country in the world imprisons so many of its racial or ethnic minorities. We imprison in the United States a larger percentage of the black population than South Africa did at the height of apartheid. In the nation's capital, 3 out of 4 young black men, and nearly all of those in the poorest neighborhoods can expect to serve time in prison. And similar rates of incarceration can be found in communities across America. 75% of this is because of arresting people for so-called nonviolent drug crimes. These stark racial disparities cannot be explained by the rates of drug crime, because studies show that people of all colors use and sell illegal drugs at remarkably similar rates. Right, so again, this is the only data that's out there. You can find a bit of information about the additive stress and the Myers model, and you can find Michelle Alexander's books and a couple other people who are really writing from the outcome point of view, what happened, right, as a result of the war on drugs, and where are we now. But there's not very much out there about that actual intersection or what our social assumptions are about intersections. Our jails are overflowing with black and brown drug offenders. In some states, black men have been admitted to prison on drug charges at 20 to 50 times greater than those of white men. And in major cities of the United States, which are really the focus of the U.S. war on drugs, as many as 80% of young African-American men now have criminal records. And that's our subject. This is one of her key points, to legalize discrimination for the rest of their lives. Right, so go back to Dean Spade, who says these are racialized and genderized systems of control. Michelle Alexander's book is called The New Jim Crow. She really suggests that that all of this results in a new caste system. It's just a different way of subjugating people of color to discrimination and keeping them out of, if you will, any role in the so-called dominant power structure.
Okay, so finally we ask that you break into small groups, 2 to 3, and actually have a discussion on what you think are some forms, and not long, just about 5 minutes or so, a short discussion on some of the ways that you see administrative violence related to substance use and gender identity that you recognize and address.